So our first speaker is Dr. Dinesh Kullar. He is chairman and head of Department of Nephrology and Renal Medicine Transplant at Max Super Specialty Hospital, Saket. He has areas of interest is high risk kidney transplant patients in lupus nephritis, induction therapy in transplant patients. He has number of publications, national and international journals, and he has received Susata Award of 2022, MT India Healthcare Award 2021. I request Dr. Dinesh Kullar.
Hello, everyone. At the outset, my sincere thanks to the organizing team for providing me with this wonderful opportunity. We all know that Ecmo has proved to be a great weapon in our armamentarium while managing these critically ill patients. However, it has its own risks, and one of them is acute kidney injury. Acute kidney injury is defined based on the increase in the serum creatinine value or the reduction in the urine output. And as per the KDIGO definition, we stage them in stage 1 to stage 3. Well, Ecmo needs no introduction to this gathering today. Briefly, to recapitulate, the veno-arterial VA ECMO is typically used in patients with refractory cardiogenic shock or combined cardiorespiratory failure, while the veno-venous VVO ECMO is used in patients with potentially reversible causes of respiratory failure. Well, the patients are sick, we all know, and that's why the in hospital mortality in patients on ECMO is very high, ranging from 21 to 37% in patients receiving VV ECMO, while it's higher, 40 to 60% in patients treated with VA ECMO. Well, despite improving survival in the recent years, acute kidney injury, along with infection, thrombosis, and bleeding, remains a major problem associated with ECMO. Well, the incidence of AKI is very high. It ranges between 26 to as high as 85%, and about 45% of patients require renal replacement therapy. Again, AKI is more common in patients on VA ECMO as compared to VV ECMO, 61% compared to 46%. Going further and looking at the pathophysiology of AKI, we will realize why AKI is so common in patients on ECMO treatment. There could be the patient related variables, there could be invasive mechanical ventilation related factors, ECMO related factors, hemodynamic variables, hormonal variables, circle related factors, and we should not forget about the role played by systemic inflammation. Well, there are issues with the mechanical ventilation in these patients. This can cause the altered hemodynamics. There could be immune mediated damage, hormonal alterations, all of these causing acute kidney injury. And if the patient is on ECMO or extracorporeal carbon dioxide removal, there is going to be ischemia reperfusion, fluid overload, continuous blood flow during the VA ECMO, and this can be associated with sepsis, hemolysis, hypercoagulability, microvascular obstruction, all of these potentially causing AKI, and of course, not to forget the role played by rhabdomyolysis and the bleeding or venous obstruction in these patients. Well, the extracorporeal support in the case of liver disease is no exception. Well, we know that there is kidney and various other organs crosstalk. If we look at the crosstalk between the kidneys and the heart, the cardiorenal syndrome, there are again the altered hemodynamics, hormonal alterations, there is an immune mediated damage, release of cytokines, inflammation, endothelial activation, all causing acute kidney injury. The lung kidney interaction is no exception. There is pulmonary hypertension, right ventricular dysfunction, there is hypoxia, hypercapnia, increased alveolar capillary permeability, and all these can result in AKI. Well, moving further, the pathophysiology of AKI in Ecmo is because of some hemodynamic variables. You can see here the non-pulsatile flow in Ecmo can cause reduction in renal blood flow, impaired corticular and medullary flow, and you can expect uh, AKI because of renal impaired renal oxygen delivery, the ischemic acute kidney injury. Well, Ecmo also has hormonal variables via its effect on the catecholamines. There is hemodynamic instability, again impaired renal oxygen delivery causing AKI. And of course, there are the treatment variables, the hypoperfusion, the hypoxia, both via lung injury or the acute heart dysfunction, typically called cardiorenal syndrome type 1. Well, Ecmo, of course, is typically associated with systemic inflammation, which is there right in the center, which could be related to the treatment variable. Systemic inflammation, in turn, causes acute lung injury and can cause the need for mechanical ventilation, finally perpetuating or causing acute kidney injury. There's a role of nephrotoxic drugs, which are so often used in these critically ill patients. There could be circuit related variables related to the procedure of ECMO. There could be bioincompatibility causing further aggravation of systemic inflammation, setting a vicious cycle, or there could be circuit related variables in the form of ischemia, hemolysis, embolisms, or acute arterial dissection, all potentially resulting in AKI. Well, apart from the older age, the coexisting comorbidities like cirrhosis or chronic kidney disease in these patients, one has to be very careful about the coexistence of high lactate in these patients, high plasma prehemoglobin, increased bilirubin, high neutrophil to lymphocyte ratio, RBC distribution with more than 14%, high inotropic equivalence, the ECMO pump speed, and the ECMO duration. All these factors have a big role to play. Now, supposing AKI happens, now these patients are critically ill and so very often would require the need for renal replacement therapy. And this is what we have in mind when we are typically thinking about providing CRRT support to these patients. This is a circuit which we are all very familiar with. But going a little further into the details, it could be the employment of a hemofilter, just putting in a hemofilter after the centrifugal blood pump, and the return is before the pump. So very easy. We'll come back to that. But if you are wanting to give the CRRT support to these patients, typically it was started by having a CRRT circuit employed after the centrifugal blood pump, taking advantage of the high positive pressures. But coping up with these high blood pressures was a problem, and that's when we decided going in favor of putting the circuit here before the centrifugal blood pump, taking advantage of the negative pressure. But here, the problem was the inadequacy of the blood flow. So finally, now more and more centers are employing this hybrid, whereby the arterial end of the CRRT circuit is after the centrifugal blood pump, while the return is before the centrifugal blood pump. So taking care of the problems of both. Well, looking at the advantages and disadvantages of the various circuits, well, the inline hemofilter may be having a low cost, no need for separate anticoagulation, but the problem is there is no pressure monitoring. It requires an external infusion device. It's less precise as far as ultrafiltration is concerned. So, can we have an independent renal replacement therapy access? Well, yes, it can potentially allow you to fine tune adjustment of solute and fluid removal. You will be able to provide renal replacement therapy independent of the ECMO procedure. It will allow you to use regional anticoagulation, and it will be a simplified circuit changing. But the problem is there will be a need for separate vascular access. There's a risk of mechanical and infectious complications as well. Higher extracorporeal blood volume is required, and technically it's more complex to manage two separate circuits. That's why we are relying more and more on RRT connected to Ecmo circuit. That's called the integrated system rather than the parallel system. And of course, we have a lot of advantages of this, especially there's no need for separate vascular access. You can have a very fine-tuned adjustment of solute and fluid removal here as well, and it avoids complications of line insertion. But there are problems inherent with such an circuit. The pressure alarms are going to be a problem. Requires a RRT machine capable of adjusting these alarm settings. There's always going to be a risk of air entrapment. Flow turbulence will cause risk of hemolysis and thrombus formation, and there could be a potential risk of recirculation as well. Now, choosing the type of renal replacement therapy in these critically ill patients who are already on Ecmo, well, conventional hemodialysis does not have a major role to play. These patients are far too hemodynamically unstable to be taken up for intermittent hemodialysis. So the choice is either between prolonged intermittent renal replacement therapy or SLED, or continuous renal replacement therapy. As we all know, we are more and more in favor of CRRT because of course, the integration in the Ecmo circuit is possible. There is a gentler and a continuous fluid and solid removal. It allows more precise control of fluid balance and offers a better hemodynamic stability. Well, there is a very significant role played by peritoneal dialysis, especially in children. But when it comes to the adults, there is less experience. But I'm sure in times to come, we'll be talking more and more about PD even in adult population. There will be, of course, the inherent risks of causing peritonitis, hyperglycemia, and it may actually interfere with the asthmatic movements as well. So the timing of CRRT has always been a subject of debate whenever we talk of providing CRRT support to our patients, and in conjunction with Ecmo is no exception. But what is the most important factor to remember is that we should at any cost avoid fluid overload, and we should try to keep our patients as close to their dry weight as possible. But it's of course a challenge to determine the dry weight of these critically ill patients, but then we should use our experience and the objective tools to assess the patient's dry weight and try to achieve the dry weight as much as possible. Well, there are interactions between the renal replacement therapy and extracorporeal organ supports. When you're providing RRT to these patients on ECMO, there is always going to be a risk of oxygenated clotting, pulmonary embolism when you are employing VV ECMO, or arterial embolism during VA ECMO. To conclude, AKI may be multifactorial in patients on ECMO therapy. VA ECMO has higher incidence of AKI. CRRT offers best renal replacement therapy modality when on ECMO. And more importantly, the AKI incidence can be reduced with experience when you use diligently the ECMO pump speed and this duration, and thereby you can significantly reduce the incidence of AKI in these very sick patients. Thank you very much.
Thank you, Dr. Kuller. As always, a very nice presentation, sir. So it is always nice to listen to you. Just a quick question, sir. Do the indications of starting renal replacement therapy, as you already mentioned, differ in these severely ill patients as compared to other patients? Meaning, except for fluid overload or other indications, do other indications, do we use a lower threshold in starting renal replacement therapy in these patients?
Well, that's a very pertinent and fantastic question, because but before I answer that, my sincere thanks to the organizing committee, Vivek especially. You've done a tremendous job, and anything associated with your alma mater will always make the former students really proud of what is happening back home or in their pride institution. So thank you very much, Vivek, and just keep it up. It's a fantastic going so far, and I'm sure people whosoever has joined are going to immensely learn today. Vikas, you as a nephrologist are quite well aware that we always say that dialysis should not be unnecessarily delayed. When a patient is not that sick, we may still be in double two minds whether to initiate therapy or not. But here, the patient is already critically ill. So any further delay could actually push them into a point of no return. So here we may become at times a little trigger happy. We may not want to lose an opportunity to address the AKI issues at the right time, and especially when the the circuit is right there in front of us. We certainly would want to be preemptive rather than delaying the treatment. Initially, there was a learning curve. We were trying to figure out as to how we as nephrologists will fit in into the whole system. Not any longer. Over a period of time, we have gathered enough experience, and I think we are much prompter. So the most important thing I would want to reiterate is at any cost, we should avoid fluid overload because that is going to be really detrimental. I would be probably erring on the other side, even if that tantamounts to slowing down the chances of recovery from the renal failure. That can be tackled later on, but then I think the initial mortality will depend more on the fluid overload state.
Thank you, sir. Any more questions from the audience on the floor? At the end, okay. So we'll be taking the questions at the end.
Okay, great.
Thank you, sir. So we now move to the second session, and the second session is addressed to. We'll be discussing about the debate. This is going to be a debate, and the topic is SLED versus CRRT. So in fact, the battlefield is changing, but the soldiers remain the same. It is SLED versus CRRT. And speaking for SLED, we have an eminent nephrologist. So as it should have been allotted to a nephrologist. So Dr. Lobo is with us, and he'll be speaking in favor of SLED. And Dr. Ranajit Chatterjee will be speaking later on in favor of CRRT. We know that he can speak in favor of CRRT even in his deep sleep. So first, I'll welcome Dr. Lobo. Dr. Lobo, please.
To agree to disagree. So, if we want an optimal form of renal replacement therapy, we would like something that's easy to use, easy to monitor for doctors and nurses. It should be adaptable. It should provide us with fluid removal without causing hypotension. It should not have complications. It should allow us easy treatment, easy drug dosing, and it should not be costly. We want our patients to have low mortalities, shorter ICU stays, shorter hospital stays, shorter ventilator stays. We want renal recovery to occur quickly. We don't want to cause additional organ damage, and we want to get metabolic correction. So this would be an ideal renal replacement therapy. And neither intermittent hemodialysis nor continuous renal replacement therapy really fits the bill for any of these, because the advantages of one are the disadvantages of the other, and vice versa. So if we could get a therapy which would combine the advantage of easy to use and high clearance of intermittent hemodialysis and also avoid the hypotensions as CRRT does, then that would be an ideal treatment. And there is actually such a treatment, and it has been variously called SLED, extended daily dialysis, prolonged intermittent renal replacement therapy, all of these things. Now, the great advantage of sustained low efficiency dialysis is you can decide how long you want to do it, and it varies from 6 hours to 24 hours in various forms in the literature. Now, more than 20 years ago, when I told my boss, we must have CRRT, he said scathingly, if you have a beautiful girlfriend, then you'll need to buy her ornaments. So if you have a machine like the Prisma Flex or the Multifiltrate Pro, they only take their own circuits, their own filters, their own fluid. You cannot use any other system once you have bought a CRRT machine. You need to buy dedicated disposables from the same company. If you put the wrong one, this is what you will get. Wrong set loaded, and the machine will tell you disconnect, you can't go forward. If you have too much of alarms in your ICU from the monitors, from the ventilators, this is what the machine will say, sound check. It can't hear its own sounds, and so it will tell you disconnect. By contrast to this,
Hello, I'm on a cold
when you go to SLED, any dialysis machine that's available in your unit and any dialyzer which is being used for dialysis will do. And over the last 20 years, I've used all these machines and others at various times. Now, about 20 years ago, also, Victoria Kumar at the University of California, Davis compared CRRT and SLED to see what they could do what they did in terms of hypotension, and she found that the blood pressures at the start, at the midpoint of these treatments, and at the end of these treatments were not different in the two therapies. She also found that both of them could do equal amounts of ultrafiltration, though SLED did it in about 7.5 hours and CRRT did the same amount in 19 hours. At the same time, a paper which was published here showed that actually with 18 hours of SLED, blood pressure dipped a little bit but then actually improved, and that was due to the correction of acidosis. And over 18 hours, as much as 4 liters of ultrafiltration could be done, and the mean arterial pressure was actually improving. Now, the biggest study which compared SLED and CRRT, and it was a good randomized controlled trial, was the rescue study. They compared 12 hours of SLED with CRRT at 35 ml per kg per hour, and they recruited 232 patients. Now, what this study showed, of course, when you go to the endpoints, there's no difference in 90-day mortality, no difference in hospital mortality. SLED is a little better in terms of renal recovery, but the CRRT, which was supposed to be continuous, was actually run for about 16 hours on average, and SLED, which was supposed to be 12 hours, was actually run for 15 hours. So for me, the important points that this study said is CRRT, though called continuous, is not truly continuous. And there's not a lot of difference between these two therapies when you come down to it, 15 hours versus 16 hours. There's no difference in the mortality at any point of time. And our own Ramesh Venkatraman, when he was at Pittsburgh, did this study in which he showed that the average treatment time of CRRT is about 16 hours a day, not 24, and the average dose is about two-thirds of what you prescribe. Now, you can do SLED without anticoagulation in a large number of patients, as many as one-third. We've done it in about 50%. In CRRT, you'd almost always require anticoagulation, and the doses required are also higher. It's often said that when you have intracranial pressure that is rising, CRRT is preferred. And this study from Taiwan, from Vincent Wu, compared the intracranial pressure and the cerebral perfusion pressure in SLED and CRRT in a crossover and showed that there wasn't any difference. So one more settle breached by SLED. You can combine, because SLED is a hybrid, you can combine it with just about anything else. Here I've combined it with the cytosorb filter. This is something I'm doing almost every day, combining with plasma exchange. Here I've combined it with an Ecmo. So you can run SLED with almost any other extracorporeal therapy you choose, which again is not that easy with CRRT with the dedicated closed circuits. Now, this is what happened in 3 centers. This is Middlemore Hospital, New Zealand. Over a period of time, they gradually gave up CRRT and replaced it with SLED. This is an Australian hospital which did the same. Over a period of 3 years, they gave up CRRT and went over completely to SLED. And what they found was no difference in the outcomes whatsoever. So they could completely do away with CRRT in every patient, including the hemodynamically unstable ones, go back to SLED, and it didn't make a difference at all. Now today we have 30 randomized controlled trials which have looked at about 3,774 patients. And what do they tell us about CRRT versus SLED? SLED F is associated, as compared to all other modalities, including all the CRRT modalities, with a 40% reduction in mortality overall as compared to CRRT. And it's also that PD, the neglected therapy, does remarkably well in terms of renal recovery, renal support, and a shorter length of ICU stay. So when the meta-analysis looks overall, SLED is a little better in terms of mortality. And the take-home points were, when you looked at individual studies in renal recovery, there's not a great deal of difference, 1.03, 1.08. This is what the meta-analysis drew as conclusions. SLED is the most effective in reducing mortality. Both CRRT and intermittent hemodialysis are actually worse for renal recovery than SLED. So for a long time, we said Okay, mortality is not different, but renal recovery is better with CRRT. It's actually not as of 2021. SLED is associated with a shorter length of hospital stay and days of mechanical ventilation. And there's no credible subgroup effect in any subgroups of patients where this analysis is concerned. What does it cost us to do SLED? Well, it costs us about 3,000 rupees a day. If we are doing SLED F, around 4,500. If you do CRRT with the Prisma Flex, it's 35,000 rupees a day roughly. And if you do it as Dr. Vivek Gupta does and as I did 20 years ago, and we published this data, it costs you about 5,000 rupees a day when you don't use the bagged fluid from Baxter. Now, it's often said don't mortality in such seriously ill patients, that's not the right thing to look at. Cost should not be a consideration when you're saving lives. But which of us wants to go to a patient's wife or mother or children and say, your patient's very serious, there are these two modalities of treatment, one of them is going to cost you about 3,000 rupees a day, the other one's going to cost you about 30,000 rupees a day. Either way, your patient is most likely not going to make it. But if you're going to spend 30,000 rupees a day, then he's going to die with a better blood urea level, with his acidosis corrected, and better blood pressures over a period of time. So, if I have to conclude, critically ill patients with CRRT could be offered CRRT or SLED, and they are actually not very different. They could be run continuously. Mortality is not affected, though SLED F may offer some advantage, and so I believe the hybrid therapies may be the most suitable. SLED is a hybrid, it can be further hybridized to combine with other extracorporeal therapies. Thank you.
I invite Dr. Ranjit Singh Chatterjee. He's a head critical care in SDNS Delhi and an honorary consultant critical care RKM Hospital. He has got various publications in national and international journals, and he has a special achievement as Fellow of Royal College of Physicians at Renal and Fellow of Indian Association of Clinical Medicine. He is a Rashtriya Gaurav Award awardee of 2011, and he has got an Academic Excellence Award at DMA ISA and a COVID Warrior Award of DMA. Over to Dr. Ranjit.
Thank you, Dr. Lobo, and thank you, Dr. Vikas, for telling that I can speak CRRT in my deep sleep. Actually, I don't know, Lobo, will you please read what is the debate? Please read it. It is an Ecmo patient. I am not here to debate between CRRT and SLED, that we would have debated. But the debate is completely different. It is CRRT or SLED in Ecmo because this is an Ecmo conference that is going on. I can rebut Logo point by point about CRRT on that, but I think Logo is not at all wrong, totally wrong in definitely defending SLED here. Yes, the studies that we have seen, at least the meta-analysis we have seen, that SLED does not have much of difference with CRRT. I agree with you. But again, I will tell you, be aware of the meta-analysis, Once you do a meta-analysis, you compare an orange with an apple, and ultimately you say, oh, the mango is so beautiful to taste. So meta-analysis, you have to take it with a pinch of salt. You have the RCTs, you have the observational studies. I can exactly show you a meta-analysis where it will be shown that CRRT has a better renal recovery than SLED. But I have not brought all these things, Lobo, because I was thinking that something I'll discuss on this Ecmo. And all right, let us see what exactly is happening during Ecmo. See, we are here to deal with the sickest of the sick patients in Ecmo. We can't take any chance out here. We just can't tell that this is good and this is bad, but whatever our experience says, that you have to follow, and let us see what does it say. And why should I go for this type of debates here? That is to be seen. Can we compare RCTs? Whenever we do any debate, we start showing RCTs, randomized controlled trials. I remember John Louis Vincent telling once in 2010, can we do RCTs in the sickest of the sick patients? Can you do RCTs on patients who are on CPR? And tell one patient that I will give 100 pressures here per minute and I'll give 130 in this. I don't know which one is good. you will ask the people, take a consent, I'll give 100, I'll give 130, please allow me to do an RCT. So will anybody allow you to do that RCT? Nobody will say, first of all, save my patient here. 100 do ya 130, save karo. So that is the point. In the sickest of the sick patients, it is a questionable thing that how much the RCTs are going to be beneficial. So as the mortality rate is very high, you see the mortality is around 80%. Ecmo. So hardly any one modality, whether it is CRRT or SLED, is going to change the mortality. That I think everybody should agree with. So we have to see how exactly we can use it and how easy we can use it. Let us see that. See, the condition of CRRT, this CRRT should be changed to cost. Continuous organ support therapy. Yes, the cost is high for organ supports. That's how I believe in that because you're giving multiple organ support. You are dealing with a lot of nutrition of the patient. You are dealing with fluid removal. That is most important. The precise fluid removal. Yes, nephrologist per se excellence of like Lovo will do it with SLED F. But again, as you see the number of machines that he has shown, there's so much of variety of SLED machines, you know, as the name also changes, PIRRT and all these things. As the name changes, the variety of the machine changes. Every different person has a different machine. So some machines are very sensitive to temperatures. Above 35 degrees it gives sounds. And I'll come to that. Apart from that, this cytokine management, treatment of respiratory acidosis in ARDS, fluid management in multi-organ failure, malignant hypothermias, poisoning. I'll give some examples here. Everywhere, this modality has some role, and that is the reason we are telling it is going towards organ support. Now, see the conditions of RRT in ICU in Ecmo patients. So, the main thing that is we are focusing on is fluid overload. You have seen Dr. Dinesh telling about that. The choice of CRRT, choice of ICU in Ecmo is CRRT. Because the fluid overload, about 69% of those who are on Ecmo who are going on this your renal replacement therapies, either for management or for presentation. They are on this CRRT is being used. Similarly, the RRT, any form of RRT. Again, the AKI is 35% and the electrolyte imbalance is 4%. This is the overall scenario of patients of Ecmo patients. And how do you remove this fluid? You remove this fluid either with diuretics or with a very visual approach given by Koterman in 2012 that you measure the intra-abdominal pressure, give some amount of PEEP of that, give some amount of albumin and then give Lasix. This is known as a PAL approach. Or you can use a precision machine which will remove this fluid, and I'm sure those who are using CRRT, they will be agreeing with me that, and if you don't agree with me, you can go by the holy book, the ELSO book that has come up. Even the 6th edition is available outside. Go and read what they have written. It is nothing but CRRT that to remove this fluid. You have to use CVVH. So here CRRT scores over SLED, you know. Similarly, see the second line. This is one of the studies I am showing you. Negative mean daily fluid balance. Now, in order to get a negative mean daily fluid balance, you need a relatively continuous therapy. And that is associated with better pulmonary compliance and better survival. This was done in fluid balance and recovery of lung function in adult patients, where CRRT was used with Ecmo. Similarly, what has been seen, as Dr. Vikas was asking Dr. Dinesh, can we start it a bit early? So they have seen that early AKI detection and management of CRRT and the same group who is using Ecmo, they should be using the CRRT. They were trained in that. That training is so important. That definitely improves the mortality. So, and a negative fluid balance of 3 liters compared to that of 1.8 liter of positive fluid balance definitely improves mortality. So, this is the point where fluid balance, the fluid management of this fluid overload that can be done by CRRT, it has been seen from these papers. And this is one of the papers from DMC itself. And in aluminum phosphide poisoning, the patients were, the blood pressure was not measurable at all. They went into Ecmo, there was severe metabolic acidosis. Most of the patients, they managed this metabolic acidosis with the help of CRRT. So this is from your own college. And this was Westerman's paper that Dr. Koller was also showing. And just see what they have written about SLED. Risk of hemodynamic instability in high-risk patients. These are basically not only coming from studies but also from observations. I still feel that observations are very important in critically ill patients. We just can't quote certain studies and say certain RCTs and this is the baseline because they are so critically ill that mortality difference will never come from a single mortality. Now the compatibility. Now you see, when you are using a Ecmo, it is just like with a CRRT. Suppose you are running a car and you say the first two wheels you run for 24 hours. Baki do jo chakka hai, the two wheels, please don't run for 12 hours. Let the car move with these two wheels. Is it possible? So when you combine SLED with CRRT in that circuit, you stop for around 12 hours. Again you start it. The whole system takes another thing. There are so many complications that can occur. And I was discussing this with many of the people who are using SLED. And they said this is one of the main reasons of SLED which can be incorporated inside might create some amount of problem. This compatibility problem. Similarly, the logistics problem. This machine, yes, it's a machine which can be, it's like ornament, which is used by the, if you have a girlfriend or your wife, you have to give a lot of ornaments as you are telling. So I think even the husbands are now taking from their wives. I think both the side is true because it's a gender neutral environment nowadays. And with there also we find that CRRT can be moved from one place to the other. Whereas for a slate machine, you need a point. Those who are working in the ICU, they need a point of the water, and that water should be ultra pure. Ultra pure water should be there, and for SLED F. And you need a point. You can't move your machine from every place to another, and then only you can put your machine. So see the logistics problem that you are having with this machine. When you are working with the sickest of the sick, you should always remember these small logistics things definitely matter, and which we normally forget because we only discuss theory. And what about the literature? There's yes, lot of literature shown about SLED and CRRT, but regarding ECMO, where is the literature? This is one paper with 7 patients. There is another patient with another paper with 23 patients. So there are total 30 patients that I have found. I don't know, there may be others. But see the literature of CRRT with ECMO. There's a lot of patients with the adult patients, in pediatric patients, in VA ECMO patients, in VV ECMO patients, in cardiac surgery patients. I can go on showing slides like this on and on and on. And only for that reason, the technical considerations have been taken care of that Dr. Kuller was saying. We know exactly where to put it, how to put it. We have that precise decision-making capability today to know exactly where the CRST has to be put. And when we do this, we get a meta-analysis like this, where more than 5,896 patients was taken, and the mortality is definitely high. It will be high. It will be high not only today, maybe after 10 years also. But see the improvement in mortality from 2016 onwards. The more we use it, the more we know about it, the more we use it correctly, the mortality improves by 20%. And this is a 2021 meta-analysis again. Yes, meta-analysis has to be taken with a pinch of salt. But at least the mortality increase, the improvement is mortality, something is being indicated here. And what about the Holy Book that is saying? This is the also 5th edition. CRRT, quote unquote, while RRT may be intermittent or continuous, CRRT is the most common form used during ACL. CRRT adequate for fluid removal and electrolyte control, increased filter life, improve fluid accuracy, and decreased ECLS and CRRT duration sometimes in pediatric patients. Use of CRRT does not increase the chance of CKD at the time of discharge. Only 4% patients, that also in the 6th edition they have mentioned. And it has been seen that with ECMO and CRRT, whatever today has been gathered, especially in pediatric patients and in VA ECMO patients, the chances of renal recovery are excellent. So if we compare this, if I summarize these things, and I'll say that especially during ECMO, because the debate was on that only, if you're during ECMO patients, you have to choose your holy grail very wisely, you know. And you have to choose whether you want a time tested one or an experimental one with those theoretical things. If you're happy with that, I don't have any problem. But if you want to use a system which basically might be compatible with your Ecmo, I think at this present moment, CRRT has no other alternative. Thank you.
As I see right wing people are having their days nowadays, so right wing people were more dominant. So I'll request Dr. Logo to please rebut.
Thank you. So, as I said, we have to agree to disagree. I agree with him at the start. There is no question about the fact that the most critically ill, the most serious patients always seem to be omitted from randomized control trials. That's the way science goes forward. We know that whenever any new drug comes, pregnant women are first excluded when the drug first comes in. Now, where do we disagree? So, the first point that was made was about the variability in the machines. But that is its very advantage. You can use any machine you want. Now, are the CRRT machines more precise in volume control than the SLED machines? The answer is an emphatic no. CRRT machines use gravimetric methods with external scales in order to measure and feedback fluid balance. If your bag is slightly supported, even by a nurse touching it at any point of time while the machine is running, the scale will read the bag's weight wrong. By contrast, all SLED machines use volumetric balancing chamber or electromagnetic flow meters, which are located inside the machine and therefore are more precise, are completely free from any external influence as compared to. For this reason, in fact, CRRT machines allow you to set a limit of how much fluid balance error you will accept before you start the treatment. The default setting is 400 ml per 3 hours. And this is a huge amount. That means a CRRT machine is intrinsically accepting 160 to 170 ml of fluid error in the course of every hour that treatment is going on. This is inbuilt. So, where is fluid balance more precise? It's more precise in SLED, and that, as my good friend said, is the most important thing when you do these treatments in Ecmo. The other issue he raised was that of cytokines. Now, there is a filter, a polymethyl methacrylate filter, specifically for SLED. In fact, Toray, the manufacturers, tell us do not use it in a convective mode. This filter will remove cytokines, and we demonstrated this in a small study during COVID. It is going for publication. We also use the Oxaris. That data is already published in the Indian Journal of Nephrology. The Toray filter specifically will remove cytokines by diffusion. It is recommended not to use it in a hemofiltration mode because then it removes albumin. So, cytokines can be removed in SLED very well and do not require a CRRT mode. My third point, which I already stressed, CRRT isn't continuous. All studies tell us that it's run on average for 16 hours a day and that 68% of CRRT treatments get interrupted. So the issue that we are running it for part of the day in terms of SLED and continuously in CRRT simply isn't true. Even the biggest trial showed us that CRRT and SLED, there was not more than 1 hour of difference in the day that they were run. Finally, the logistics. I agree very much that SLED requires ultra pure water, but it is possible, and we did this. You can take your ultra pure water also along with your machine to the bedside. Fresenius makes a portable machine. It costs 12 lakhs. You can use that machine along with the machine, converting tap water to ultra pure. If you cannot, we designed a machine which costs one-tenth what Fresenius's RO machine does, and we used it at any point in the hospital for SLED. In addition, we built for our pediatric ICU a stainless steel 316 grade tank with a stainless steel pump which collects the ultra pure water and transports it to do SLED anywhere where it's required. So logistical problems for SLED can be easily overcome when you want to do it. Thank you.
So just two things I'd like to ask. So do you ever looked at different dialysate flows regarding hemodynamic stability, like 100 ml per minute, 300 ml per minute. So, is there any difference? Because what we are more worried about is hemodynamic stability.
Yeah, 100 ml per minute. If you can go down on the 5000, there's only one machine, the 5008 machine, which gives you 100 ml per minute. But the most defining feature for hypotension is the ultrafiltration rate. And we demonstrated in a randomized control trial that 4 ml per kg per hour is optimum and not 2 ml. We actually randomized patients in SLED to 4 ml versus 2 ml. We thought 2 ml would be better than 4 ml, but 4 ml proved better. The only data from worldwide studies which has come on the optimal ultrafiltration rate comes from retrospective analysis. Raghavan Murugan has done about 2 or 3 analysis, and the biggest one was from a post hoc analysis of the Renal study, where they said 1 to 1.7 ml per kg per hour appeared to be the optimal therapy. But that study had only CRRT patients. There was no SLED in it. But Murugan's other paper says if you do less than 25 ml per kg per day over the in of ultrafiltration, then what Ranjit was bringing up also, you will fail to achieve a net negative balance. So ultrafiltration is the defining factor which actually triggers the balance between negative balance to improve your oxygenation versus getting hypotension.
Any questions from the house? Most welcome. Any questions or comments
So,
from?
I can just.
Sure.
I'm not rebutting.
Sure.
I'm not rebutting. This is the beauty of our debate, that we are not here for collision but some cohesion. And we are basically not here to confuse you, but we to come to a common conclusion actually. CRT is right. 400 ml per 3 hours, that is, see the precision of this machine. You take it otherwise. The precision of the machine, that is 400 ml per 3 hours, even if you touch it, it gives around 10 ml, 20 ml when you touch the machine. So that means you have to be very precise where you're using the machine. If the machine moves, it will around 10 ml, 20 ml. So you can know exactly where exactly you are going wrong if you're inside the ICU for 24 hours. So that is one of the big problems which Lobo faces maybe, and it's India faces. That is, we have to have our nephrologists walking by side with us for 24 hours inside the ICU. Then they will understand exactly what you are following every hourly, that the charting that we are doing, that hourly charting that is done by the intensivists, that makes a big difference, and we can understand exactly where the fluid balance, where the problem is going on. About the money, yes, Lobo is telling that we should not, but I feel when you are doing Ecmo, especially Lobo, either it is done free without cost in a government hospital, or it is done in those hospitals who can afford it. So those who can afford a 1 lakh rupees a day, if they have a machine which can be more precise, in fact more easy to use, more trained by the nurses, they can spend another 20,000 rupees a day. So basically the machine yet, unfortunately, is still not for that middle class. You must agree with me. Because we can't spend that amount of money. Even myself might not spend that amount of money. So these things are there. Cytokine removal, yes, thank you that the new one has come up. I hope that studies like UFAS and UFORIX will come up slowly to prove that yes, those filters are also good. And I again congratulate Lobo to make that portable one. And I also tried following you that portable. He has made a beautiful portable RO machine along with that. We have also tried to make it. It's quite cost effective. And I think you can also try with your sled machines. Sled will become more popular. I am also using sled. But as the debate is here, and he is also using CRRT, so we'll have it, discuss it, and laugh it over a cup of tea outside. Thank you so much. Thank you for your patience.
Thank you both the speakers for nice presentation. And I'd hand over the mic to organizing team.
Thank you, speakers and moderators, for this very interactive session.